Critical thinking and coding tips for Chapter 16. Okay, our first critical thinking question: what is the difference between exacerbation of asthma and status asthmaticus? An answer: asthma is a chronic disease that affects the airways of the lungs and should always be coded as a secondary diagnosis when documented by the physician. When a patient has an exacerbation of asthma, it's an increase in his or her symptoms, which can include difficulty breathing, wheezing, and/or shortness of breath. If a patient does not respond to treatment given, such as steroids or inhalers, and the symptoms become worse and life-threatening, it's then considered status asthmaticus. In both instances, the physician must document the acute exacerbation or status asthmaticus for either one to be coded. In the event that neither is documented, only the code of asthma, which is 493.90, can be coded. Next question: what is the significance of gram stains and cultures as they relate to coding pneumonia? Our answer: both gram stains and cultures can help determine the cause of pneumonia. A gram stain can determine gram-negative or gram-positive organisms, but a culture can determine the exact bacteria, and therefore is commonly the method to determine the type of pneumonia and the kind of antibiotic to be given for that specific organism. Regardless of any laboratory test that is performed, a coder cannot code strictly from these findings. The physician must document the specific kind of pneumonia for it to be coded as such. If a coder reviews the laboratory and radiology findings and sees a potential to code a specific pneumonia, he or she should query the physician, pointing out the laboratory and/or radiology results in the query. Okay, and our last question: how is respiratory failure coded with a drug overdose? What if the patient is intubated and put on mechanical ventilation? Which guidelines apply? And our answer is: if the patient is diagnosed with a drug overdose and respiratory failure, the drug overdose and/or poisoning code is listed first, and then the code for respiratory failure. It's incorrect to sequence the respiratory failure as principal because the poisoning code guidelines take precedence over the code for the resulting condition. This is regardless of whether the patient was on mechanical ventilation. The poisoning coding guidelines still apply. Okay, now we're going to cover some coding tips for this chapter. Respiratory failure as the principal diagnosis guidelines. Now previously, there were very specific guidelines that addressed respiratory failure. However, those rules have now changed for the better. Respiratory failure can be coded as the principal diagnosis as long as it meets the definition of principal diagnosis, which is the condition established after the study to be chiefly responsible for occasioning the admission to the hospital. Now, different scenarios of coding asthma. You have asthma with COPD would be coded to the 493.2 category. Asthma and acute bronchitis is 493.0 to 493.9 and 466.0 for the acute bronchitis. Chronic obstructive emphysema associated with asthma is coded to 492.8 and a code from the 493.0 to 493.9 range. Reactive airway disease codes to 493.90. Now, either chronic obstructive bronchitis or asthma superimposed on intrinsic asthma codes to 491.2 and 493.10. Now we're going to discuss the differences between these common lung disorders. And the first one, atelectasis, which is a collapsed or airless lung. This diagnosis can be determined by performing a chest x-ray. Treatment is typically suctioning followed by vigorous respiratory and physical therapeutic measures. If the atelectasis is due to a mechanical obstruction, a bronchoscopy may need to be performed to remove the obstruction. Next is pleural effusion, which is fluid in the pleural space. This diagnosis can be determined by performing a chest X-ray. It is commonly treated with a thoracentesis to remove the unwanted fluid. And lastly is a pneumothorax, which is air in the pleural space. This diagnosis can be determined by performing a chest X-ray. A small pneumothorax requires no special treatment. If the pneumothorax is large, a chest tube might be introduced with a water-sealed drainage valve that permits air out of the pleura but does not permit air to enter the space. Okay, next we're going to discuss coding respiratory syncytial virus, or RSV. If RSV is documented with acute bronchitis, two codes are required. Code the acute bronchitis, which is 466.0, and the RSV, which is 0769.6. If RSV is documented with acute bronchiolitis, use only one code, which is 466.11, acute bronchiolitis due to RSV. Now, the different procedures that can be performed with a bronchoscopy. Okay, it can be done diagnostically to view the inside of the lung, and it can be done as an approach to perform bronchial or lung biopsies or for a bronchoalveolar lavage in order to diagnose infections. Okay, and finally, we're going to review these given different scenarios, in which cases would the respiratory failure be coded as the principal diagnosis. The first one, a patient is admitted with severe shortness of breath and is intubated and mechanically ventilated immediately on arrival to the ER. Several tests were performed and it was determined that the patient's respiratory failure was due to pneumonia. The patient was placed on antibiotics and was able to be extubated and discharged on day 3. Because the reason for admission was respiratory failure, it can be sequenced as the principal diagnosis. The etiology of the respiratory failure was pneumonia. However, this is an underlying respiratory condition, so respiratory failure should be sequenced as principal. Number 2, a patient is transferred from a nursing home with left-sided weakness and difficulty breathing. On arrival to the hospital, thrombolytic therapy is started and the patient is intubated and mechanically ventilated. The patient is diagnosed with a CVA and acute respiratory failure. In this instance, because the condition that accompanied the respiratory failure was a non-respiratory condition, either one may be sequenced as principal. Now, using the MSDRG grouper software, enter both diagnoses to determine which one optimizes the payment to determine which should be principal.